Welcome to Q&As. I'm delighted to begin a new two-part series on low vision. We're going to start today with Dr. Michael Rivers, who I will introduce in a minute, and then next time we will have low vision devices and assistance. So today we're talking about the causes of low vision. Dr. Rivers, I'm delighted to have you come today, and let me tell you a little bit about who Dr. Rivers is. Dr. Michael Rivers is on the staff of the Retina Center of Washington. There's an office right down the road here that many folks here at Greenspring are familiar with. In addition, Dr. Rivers is a board-certified ophthalmologist and an assistant professor of ophthalmology at the School of Medicine at Georgetown University. So we're just delighted to have you come today.
Thank you very much. I'm very happy to be here.
Well, we certainly have a number of folks with vision issues here at Greenspring, and we're all eager to find out what the causes of low vision are.
There are many different ocular problems that can cause poor vision. My area of expertise is in the retina, which is in the very back part of the eye. And the number one cause of poor vision in the age group here at Greenspring, of course, is macular degeneration. And age-related macular degeneration is a disease where the center of the retina is damaged, and sometimes that damage can be repaired, and sometimes that damage cannot be repaired.
All right, that's a progressive disease.
That's correct.
By and large. Does it always lead to blindness if one lives long enough?
It does not. There are actually varieties of macular degeneration. In fact, there are two major categories. The first is called dry. Everyone always has dry macular degeneration first. Dry macular degeneration means that the pigment underneath the retina wears out. Just as many other parts of the body wear out as we get older, that pigment starts to wear out. And if the pigment wears out quite severely, it will affect the vision. The pigment is necessary to feed the retina, and if the retina is not fed appropriately by the pigment, the retina can't do its job, and people are partially sighted.
What do you mean by feeding the retina?
So the retina is a very unique tissue. It is actually brain tissue that's outside of the brain. It is nervous tissue that has a very specialized function. The rods and cones convert light to electricity, and that is very hard work to do. So there are two different blood supplies to the retina. There are blood vessels on the surface of the retina, and then there are nutrients that are given to the retina by the pigment layer underneath the retina. And it's this pigment layer that starts to wear out.
When you say wear out, simply disintegrate?
Yes. The cells are a thin layer underneath the retina, and parts of those cells will wear out. And we will look inside the eye, in fact, and see areas that we call atrophy, geographic atrophy, because it's in a circle or in a geographic location. And those areas of pigment that are worn out do not service the retina, and the retina overlying that pigment does not work well. That dry degeneration is currently something that we do not have any treatment for.
Are you anticipating that there may be treatment at some point?
We are interested in certain clinical trials that have just started. In fact, there have been some trials where pigment cells derived from stem cells have been introduced surgically underneath the retina, and the retina has started to function a little bit. Those trials are very, very early, however, and I would not expect results from those trials for another 5 to 10 years.
Where are those trials being held?
There are two major centers currently. One is in Boston, one is in California. Actually, I'll be in Chicago next week at our national meeting learning a little bit more about the expansion of those trials. We're hoping that the Retina Group of Washington will be part of those trials in the next year.
Oh, is that right? Well,
That's
now
correct.
that's an exciting piece of information. Would you assume that your current patients would be eligible
Yes.
to be part of that clinical study?
The earliest studies are usually only for people with quite severe disease, however. So anyone who had any level of functioning currently would probably not be a candidate for these early trials. In fact, the earliest trials may be for more specialized diseases such as Stargardt's disease or congenital diseases where the pigment is completely damaged, such as retinitis pigmentosa, because those patients in very advanced forms have no vision at all. But ultimately, this research will benefit people with advanced dry macular degeneration.
Well, that's, I think, very exciting news for a number of people here at Greenspring who have quite advanced retinal issues. When will you learn whether...
We will probably be hearing in the next 4 to 6 months if our company has been chosen as one of the sites for this research project.
Well, that's extremely exciting news. All right, other than age-related macular degeneration, then, are there other, you're indicating that there are other causes?
So the other side of the coin with macular degeneration is that there is also a disease progression that is called wet macular degeneration. So to finish with macular degeneration first, wet macular degeneration is a disease where blood vessels grow and bleed, and that can also do damage to the macula. Now, there are treatments for that disease, and in fact, many people who are watching this video will be shaking their heads right now because they've been receiving shots inside the eye for months and months. And there is a medication that we inject in the eye. That medication is very effective at treating the wet form of the disease. It does nothing for dry macular degeneration, but the abnormal blood vessels that grow with wet degeneration are very effectively treated by this series of injections. We can make these blood vessels go away and we can prevent blindness. But there is also usually a bit of damage done to the macula, again, leaving patients with damaged retinas, and so low vision can be very helpful for that group, even if we have their wet disease under control.
All right, so that leaves some permanent damage in some cases.
It does. It does. It also depends when we are able to start the treatments. If someone has wet degeneration for 2 or 3 weeks, we're very successful at having them return to their normal vision. But if people have had the wet degeneration for several months, there is certainly going to be more permanent damage done to the macula by then, and we can't repair that permanent damage. We can prevent future damage with the injections, but we can't repair any damage that's been done. In fact, it's quite important for patients to screen themselves at home, and we give patients a piece of graph paper and ask them to check their vision at home, looking for any change in their vision. And that's true with any of the diseases we're going to be talking about today.
The early
change,
intervention.
That's correct. Any change in vision, we want to hear about it right away, because the earlier the intervention, the more successful the intervention.
All right, that probably can't be stressed too much, can it?
That is absolutely correct.
All right.
We are very, very anxious to see people as soon as they have a problem. Our office is certainly understanding that if people have new problems, they should get in within a day or two. We're happy to fit them into our schedule and take a look, and if there is a new problem, then we can treat it much earlier.
All right. Well, if we get one message across today, that may be the most important one.
I would completely agree with you.
All right. That sounds absolutely critical. All right. So there's wet and dry age-related macular degeneration, and is that the primary cause of low vision?
That is certainly the primary cause of low vision in this age group. There's absolutely no question. But there is a very large group of patients who also have diabetes, and diabetes is probably the second most significant problem for patients who need low vision. Macular degeneration is a disease where the pigment has been damaged. In diabetes, the blood vessels on the surface of the macula are damaged and can cause fluid and scar tissue in the macula.
All right. Does that act the same as macular degeneration in that it's the central vision that is destroyed?
That is absolutely correct. The macula is a location in the retina. It is the center of the retina, It is the area of the best visual acuity. It is the optical axis. And so any small change in the macula affects the vision quite profoundly.
All right. In both cases, peripheral vision is retained for some length of time.
That is absolutely correct. In fact, that is one of the reasons that low vision rehabilitation can be helpful. As a specific example, if patients have a very small but very dark spot in the middle of their vision, fine print may be difficult to see.
Yes.
With low vision aids, magnification is used to enlarge print to have the words move into that surrounding retina that is still healthy and have patients be able to read again.
So you're actually reading with your peripheral vision.
That is correct. That is correct, which is why it is so important for us to limit the damage in the macula, because if we can keep it small and keep it limited to small parts of the macula, there are other parts of the macula, other parts of the peripheral vision that continue to work.
Okay, well that all makes sense. Okay, that's very helpful. All right, so retinal neuropathy, is that?
Diabetic retinopathy
Retinopathy.
is the technical term, and specifically the blood vessels on the surface of the retina are damaged. There's two major types of damage. The blood vessels obviously bring blood in, feed the retina, and then the blood is taken out. Sometimes that circulation is impaired. Patients will have problems where the artery doesn't bring blood to the retina. Other patients will have problems where the vein doesn't take the blood out of the retina. Both of those can cause damage to the retina. Sometimes we can repair that, sometimes we cannot. In addition, those blood vessels are pipes, and sometimes the pipes become leaky. And if the blood vessels leak, it's just like if you have leaky pipes in your basement. You've got fluid that builds up in the retina. The retina is electrical tissue, and with extra fluid, it does not function very well.
Right, puts pressure on the...
That's right. The retina's job is to convert light to electricity, and the retina can't convert light to electricity if it's underwater.
Now, Dr. Rivers, is that also a progressive situation?
It can be. In any of these diseases, whether it's macular degeneration or diabetes, these are diseases that we do not cure, we manage. So these diseases can progress, even with treatments. But with our treatments, and we have treatments for diabetic retinopathy as well, that I'll be happy to chat with you about in just a second. But with any of these treatments, we can manage the complications of the disease, but we can't cure people's macular degeneration or cure people's diabetes. They still have the disease. Even if their diabetes is under perfect control, in fact, the retinopathy could progress.
All right. How do you treat retinopathy?
So when we have patients with poor circulation, we want to find out where the poor circulation is. It may not be in the eye. In fact, when people have problems with circulation where the blood doesn't come to the eye, it is usually a problem with some of the large blood vessels in the neck or problems with the heart not pumping hard enough and the blood won't get into the eye. That's not truly an eye problem, even though it affects the vision, but it would certainly be something that could be addressed. Patients, for instance, have poor vision because they have a blockage of their main artery in their neck. That's called the carotid artery. And there is surgery that can be done to open that artery, restore blood flow to the brain and to the eye, and the vision gets better. Similarly, there are sometimes problems where the blood can't leave the eye. Those are also usually problems with hardening of the arteries. That's usually a systemic disease. We have patients visit their internist. We have them check to see that their blood sugar is under control, make sure their blood pressure is under control, and make sure that their cholesterol is not too high. Those are the three major problems that can affect the body and can affect the circulation of the eye. Blood sugar levels, blood pressure levels, and cholesterol. So it's very important that any diabetic have those checked routinely by their internist.
All right. And again, the emphasis on if there's a change and you notice this, come in immediately.
That's correct. Now, there are sometimes ocular treatments that we prescribe for patients that have leaky blood vessels, and the example of leaky blood vessels in their basement. We have leaky blood vessels in the retina, and fluid builds up in the macula, in the center of the retina. Well, one of the treatments is the same treatment that we use for wet macular degeneration. We have a medication that we inject inside the eye. That medication goes to these leaky blood vessels, causes them to stop leaking and bleeding. The fluid in the macula goes away and the vision gets better.
All right, so that's treatable too.
That is treatable. There's also a very common treatment that we've been doing since the 1970s where we use a laser to seal up the blood vessels that are leaking. And the laser treatment has its benefits and its disadvantages. But the laser is quite an easy treatment. It's just a series of bright flashes of light given in the office. There's no pain involved. And very gradually the fluid in the retina will go away as these blood vessels have been sealed up by the laser.
Are you using, which are you using primarily these days, the shots or the lasers?
I would say that it's a combination of the two. We may have patients who come in who have lots and lots of fluid that are not a good candidate for the laser because there's so much fluid that the laser doesn't work. We would start them with injections. We may give them 4 or 6 injections over a 4 to 6 month period because the injections are given on a monthly basis. At the end of that treatment, we reevaluate, and we may find that the fluid is 50 or 80% better. At that point, the laser treatment may be a better option, so then we do laser to get the rest of the fluid to go away, and also so that we can stop doing the shots.
I see. All right.
We have other patients who present very early with a very small area who may be amenable to laser, and we do that right off the bat. So we use the two in combination depending on what the patient's problems are.
Okay. All right. Do you use the lasers with the laser treatment with macular degeneration as well?
Laser treatment used to be the only treatment for macular degeneration until about 10 years ago. But it never worked very well. Laser treatment for diabetes, we have a good target and we're not damaging the tissue. When we did laser treatment for macular degeneration, we did not have a good target. We had to treat a very large area, and we would also damage the healthy retina on top of these abnormal blood vessels.
All right.
So it was not very effective. So now we no longer use laser for macular degeneration.
I see.
One of the huge benefits of the injections for macular degeneration is that we're introducing the medicine in the eye, which percolates through the retina and does not do anything to the retina and targets the abnormal blood vessels. So it's very effective at that. So since the injections were invented about 10 years ago, we have no longer used laser for macular degeneration.
All right. Well, that's very helpful. All right. So those two, and are there other major causes of low vision?
Yes. We have patients who lose vision from glaucoma, but that has to be very, very, very advanced glaucoma. Unlike macular disease, glaucoma affects the peripheral vision first and does not affect the center of the vision.
Leaves the central
That's
vision.
correct. But if people have very advanced glaucoma, that can damage the center of the vision, and low vision may be helpful for those patients as well.
All right, tell us what glaucoma is.
So glaucoma is a problem where the inside of the eye has a high pressure, and that pressure puts pressure on the optic nerve and very gradually decreases circulation to the optic nerve and kills optic nerve cells.
All right, now let's go back and remind us about the fluid in the eye and what this is like.
So the eye is a ball, and the inside of the ball is filled with a jelly called the vitreous. The vitreous humor is mostly water. It helps to fill the eye, but it doesn't have any true usefulness.
Is it like gelatin?
It is, mostly water, but still has some substance. As we get older, it breaks down and it's more watery. It doesn't really have any significance. Sometimes the jelly will be cloudy and people will notice little floaters.
Oh,
and that's
is that
the jelly
because of
becoming
floaters?
cloudy.
All right, is it too much fluid in the eye?
That's correct. So what happens is many people have too much fluid in the eye because there is production of fluid in the eye and then there's a drain in the eye. And most commonly, the drain is plugged up, so it's harder for the fluid to get out of the eye and the pressure in the eye will go up. That pressure is not felt. This is not something that causes pain. There's no sensation, but very gradually the pressure causes damage to the optic nerve. The optic nerve is quite a unique nerve.
And that's at the very back of the eye.
That is correct. The optic nerve takes all information from the retina and takes it back to the brain, and the brain processes that information so that we can see. If that optic nerve is damaged, then the vision is lost. The optic nerve is 1.2 million connections in a space of 1 millimeter. So it is a tiny nerve, but 1.2 million connections go back to the brain. With patients who have glaucoma, those 1.2 million connections diminish very gradually, and fortunately at the edge of the retina, so that peripheral vision is lost first. That, on the other hand, makes it a problem because people don't notice the visual
I
loss.
was going to ask about that.
They don't have pain from the pressure. So glaucoma is a disease that needs to be screened for. It's very important that people have a glaucoma screening examination once a year.
And this simply measures the pressure against the eye.
That's correct.
Do I remember correctly?
That's correct. Patients will go to the eye doctor, and there's two major ways of measuring the pressure. One is to puff on the cornea. Another is to shine a blue light, and the blue light is it activates a dye, a yellow dye that we put in the eye called sodium fluorescein. So people will notice they have a yellow tears after the glaucoma test, and they get their pressure checked. But that screening needs to be done on a routine basis at least once a year.
All right. What kind of proportions of individuals? Let's talk about numbers here.
Yeah.
What kind of percentages or proportions of people, let's say over 60, have these particular diseases?
Patients over 60, there will be a high percentage of patients with age-related macular degeneration. That doesn't mean that it is affecting the vision, but after 60, we will start to notice some gradual wearing out of the retina, and that could be as many as 50% of people over the age of 60.
50%?
Yes, it's very
have
common.
Some, oh my heavens.
Now, again, this may not affect their vision.
No, but that there you can detect some macular degeneration in something like 50% of
That's
the
correct. There's
population
some
over
groups.
60.
Okay?
My heavens.
Macular degeneration is still the leading cause of blindness. Even with these treatments that we've talked about, it is still the leading cause of blindness in people over the age of 60.
All right, so the wet is treatable, the dry is not
Correct.
yet.
Correct.
And one would hope that with these clinical trials,
That's
perhaps
correct.
there may be some
That's right.
with the stem cell research. But you
And-
think that's going to be quite a ways down the road?
That before that would be available widespread, that would be 5 to 10 years.
All right. All right. And with the retinopathy, you're treating with the same shots?
That's correct.
And is that pretty effective with most
Yes.
patients?
Diabetic retinopathy could be 10 to 15% of people over the age of 60, and that's increasing.
Yes.
Unfortunately, diabetes is a disease that is a growth industry for retinal specialists. We see more and more people with diabetes. My daughter recently brought back a T-shirt for me that says "Eat more kale," and the reason is that we want people to be aware that certain dietary choices can affect their weight and certainly increase your risk of diabetes, and kale is very good for you, so eat more kale.
All right.
But the treatments of diabetic retinopathy are excellent as long as people have good control of their blood sugar.
All right.
There is a specific blood test called the hemoglobin A1C, or glycosylated hemoglobin, that gives an idea of how blood sugar control has been over the last 3 months. Any diabetic who comes to our office, we ask them what that is. We want them to understand that they have a role in managing their disease. This isn't a disease that we fix. We work with them, but they have to work with us.
All right, so there's a
And
direct correlation.
That's
then.
right. Anybody who has a good hemoglobin A1C has control of their blood sugar. The treatments in the eyes work better.
All right.
Patients who do not have good control of their blood sugar, these treatments may not work as well.
All right. Now, with glaucoma, what is the situation there in terms of treating, curing?
So glaucoma is also a disease that we do a very good job of managing. Glaucoma is usually treated by a general ophthalmologist, but there are glaucoma specialists for more advanced forms of glaucoma. Either a general ophthalmologist or a glaucoma specialist first try eye drops to help control the pressure in the eye. If those drops work, then patients can have a stable glaucoma for decades. There are some patients where the glaucoma doesn't respond to the drops, and there are laser treatments and surgical procedures done specifically by the glaucoma specialist that would be helpful in those more advanced forms.
All right. With early treatment, early intervention and treatment, is there any reason why that should progress to blindness?
Actually, for patients that have glaucoma, if they're caught early and they respond to drops, there's absolutely no reason they should be blind.
All right. All right. Well, I see our time is coming to an end here. This has been extremely interesting and helpful. I've certainly learned a whole lot, and I'm sure most of our watchers absolutely will as well. Is there anything, Dr. Rivers, you'd like to leave us with before we close up here today?
I would just like to emphasize that, unfortunately, our bodies do break down. And as we get older, there are parts of the eye that break down. And a good routine exam once a year is extremely important for everyone, not only to screen with glaucoma, but to look for things such as cataracts, to look for retinal problems that may not be symptomatic, and that a yearly exam is very important.
Well, that sounds like excellent advice. This has been so helpful, and again, many thanks.
You're very welcome. Thanks for inviting me today.
Thank you for joining us today. We'll see you next month.